that patients with diabetes have a higher risk of cancer. It's not new information. It's been known for a long time. Regardless of what medication you might take, diabetes alone increases your risk of cancer. Obesity increases your risk of breast cancer tremendously. So these things are all important. If you're not diabetic and never going to be diabetic, is sugar bad for you? I can't prove that. I really can't say that. Yes, Ken?
I had a question about the evolution of medications for diabetes, and it's a little technical, but you know, when I started back in practice of medicine, the insulins that we had, I don't think were as good as they are now.
Agreed.
For example, for the audience's sake, we had something called regular insulin, which is still available, I think, now. It's still used. But you had to inject it, what was it, an hour before a meal, half an hour before a meal, because it took that long for the drug to really take effect to counteract the increase in blood sugar that you get when you eat. And now we have insulins that work much faster than that, so you can take them with a meal, which is obviously a lot easier to do. We also have these long-acting insulins like Lantus and Levemir, which, as an internist, I find incredibly easy to use. It's usually one shot a day. It doesn't cause low blood sugars very much because it doesn't peak and then come back down. And it does bring blood sugars down pretty well in a lot of my patients. So the reason I'm belaboring this a little bit is that you sort of have these in-between drugs that you mentioned. The TZD drugs, the Onglyza, Januvia drugs, some of the other injectables that are attractive but have their, like Victoza. To me, they're kind of in the middle because you have these cheap sulfonylureas that everybody can use because they're inexpensive and they bring your sugars down. And then on the other side of it, you have these insulins, which are fairly easy to use and work pretty well. And then you have this sort of middle ground that I find very difficult to negotiate, mainly because of the expense. Also because of a lot of the talk, the buzz, Actos primarily, because this caused cancer. There were two other drugs in that category that were withdrawn because of toxic effects. And then you have also the negative fallout from drug companies that are flogging these drugs, and a lot of people are suspicious about that. They don't really know a lot about them, they're new drugs. So as a practitioner, I'm a little confused, first of all, about where to go with this, and secondly, I'd like to use more of these drugs in the middle, but I find that there are a lot of barriers to doing that. So, can you comment at all on that situation?
Sure. And it's a tricky question. What Dr. Green is pointing out is that we have these standard care, metformin, sulfonylurea, and now we have these new guys, the DPP-4s and the GLP-1s, which sort of stand between old-fashioned medicine and having to convert over to insulin. I really think that you can use the DPP-4s and GLP-1s in two ways in the middle here, okay? You certainly can, if you have failed metformin, sulfonylurea, you've done your bargain basement approach, standard care, $4 prescriptions, and you're still not at goal. That's when you should think about adding these medications, because all the studies done demonstrate that addition of DPP-4s or GLP-1s to combination therapy have the same effect as if they were in there by themselves. They're not synergistic, but they're additive. So typical for us is to add a GLP-1 agonist to somebody who has failed metformin or metformin plus something, because it has the added benefit of weight loss, lowering blood sugar without the risk of hypoglycemia, which you obviously have some of when you add basal insulin. So in controlled trials of Victoza, Bydureon, Byetta versus Lantus, you get the same A1C drop, but the Lantus and the Levemir and the whatever else, NPH, cause weight gain, whereas the Victoza or the Byetta causes weight loss, and with no hypoglycemia. So equal A1C lowering, better benefits. The cost between insulin and the injectable GLP-1s is more comparable, I think. Insulin's very expensive. I mean, the newer insulin, yes, NPH and regular, we really hardly ever use anymore. except for patients who have no insurance and can't afford insulin, and then it's cheaper. But it is much harder to manage NNR than it is Lantus, Levemir, Novolog, Humalog, or Pedra, because of the higher risk of hypoglycemia. A1C change, pretty similar, but again, you have to take a regular half an hour before the meal, whereas you can take a Pedra half an hour, 15 minutes before to 20 minutes after, giving you a bigger window to end up with similar control. So I think that in that situation where your A1C is 8, but you're on oral agents and you want to get it down to 7, that's a good place for these injectable medications. The insulin will do the same. It'll get you to the same goal, but with that added risk of hypoglycemia or weight gain. If that's not I mean, insulin's a perfectly good option, but it has these two little negatives that are thrown in there. And many patients will be on insulin. One of the ways to look at this is if you put them on a GLP-1 agonist, which is injectable, and it's not successful, you've taught them injections already. The switch to insulin is really easy. They've already got the pen down. Now, one of the problems that we have with Lantus Levemir approach, as most practitioners use it, is that we don't use it in the way it was meant to be used. And this is really Sanofi's fault, because they promoted the heck out of this, which is fix the fasting first. So this is the goal. Get your fasting blood sugar down, because then your pancreas might recover and deal with the rest of the day. So what do? We give the patient Lantus or Levemir at bedtime to get the fasting blood sugar down to 110. But they're going to bed at 200, because all the calories are consumed. Let's have a vote of hands. Whose biggest meal is not dinner? Right? I saw somebody yesterday. She weighs, I can't weigh her because she refused to be weighed. I've known her for 10 years. She's never gotten weighed in all this time. She won't get on the scale. But she's round. She has water for breakfast, a salad for lunch, and then eats 3,000 calories between dinner and bedtime. This is the way she said, I'm not hungry during the day, but I'm really hungry in the evening. I said, it's because you don't eat during the day. That's why you're so hungry in the evening. Which is what typically we do. We're dieting for 12 hours a day and feeding ourselves to death for the last 4 hours. This is what people do. So we end up using this long-acting insulin to bring the bedtime blood sugar down. That's not what you want. You want to keep the blood sugar constant between bedtime and the morning, but we're using basal insulin to accomplish that. If the lovely combination, which we're working on, is insulin plus the GLP-1, insulin to make the fasting blood sugar normal, and the GLP-1 to prevent those rises after meals. Now, none of them are, Byetta is approved for use with insulin now, so you can do Byetta with insulin. Victoza and Bydureon are not approved yet with insulin, but that's sort of a magical combination in my mind. You can also use Januvia with insulin. You can't use Onglyza or Tradjenta with insulin yet, but this is just a matter of time. The advantage of that combination is, and I see this in the hospital all the time, you have somebody who's 85 years old, lives in a nursing home, blood sugars are just way too high, and you want to get the blood sugars down, but you don't want to give them 4 shots a day. This really seems unreasonable for both the nursing home and for the patient. But you can't let them run around the way they are because they're symptomatic, getting urine infections, coming back and forth to the hospital. So we give them 1 shot at night, get the blood sugar somewhere near decent, then give them a DPP-4 inhibitor to try to prevent those post-meal rises during the day. 1 shot, 1 pill is a pretty reasonable combination. So I think it's that's where we use them most of the time, in that combination. Either before insulin or with insulin, before you have to go to multiple daily injection kind of therapy. Yes?
Yes, I've heard on the news in the last 2 weeks several times about bariatric surgery, that weight loss surgery will bring the sugar down, will correct diabetes, and I think they even went on to heart disease.
This was a study that published that I haven't actually read yet. You know where the study is? It's in a journal. I don't know where this is hiding. They get the pre-release information, they give you the highlights, and you have to read it between the lines as you know about these things. So we've known for several years.